This is largely a talk about lung cancer. It should largely be a refresher, but also a bit of up to date and a bit of current status of where we're at and what's going on in lung cancer. So now, if the talk is a little off target, goes a little long, or is a little short, or is a little higgledy-piggledy, it's because my wife has been away for the last week, and these two, although they were very attentive, didn't provide a lot of useful feedback. They're actually sitting on the central heating vent there. So look, just to put it all in perspective, primary care physicians have a greater chance of impacting the outcomes of lung cancer than oncologists, and that's purely because it's all about finding cases early. So through this talk, I hope to show you that sort of prognosis is dependent on stage, that stage is dependent on early detection. Early detection is all about suspicion, and suspicion is about awareness. And of course, all of this is eclipsed by primary prevention. So we'll go through some lung cancer statistics, the evidence around screening, case detection, what happens to patients when they hit the hospital. We'll focus in on some radiotherapy and then some of the newer exciting objects. So Victorian incidence, it's the fourth most common new cancer, but it is the leading cause of cancer death, and that probably comes as no surprise. And you can see that the incidence of lung cancer in males has been decreasing over the last 30 years, but in women it's actually been slightly increasing, or over the last few years been steady. Now this is the first sort of key fact that I want you all to be aware of, is that more women die of lung cancer than breast cancer. And I don't think most people are aware of that, and definitely it's one of the key things I'd like you to take home and just think about. So you can see those lines in Victoria crossed over in about 2006. In the US, this is predicted cancer deaths over the next year. We'll see that lung cancer vastly exceeds the combination of prostate, breast and bowel. Now it's easy to see why we have a lung cancer problem, because the advertising is so seductive. And who wouldn't want to follow that advice? So as early back as 1950, there was a link between tobacco and cancer. It wasn't limited to our patients. And smoking is bad for your health, and it's bad forever. So 80% of lung cancers are due to smoking, and that's about 90% of cancers in men and about 65% of cancers in women are due to smoking. Lifelong smokers have about 1 in 15 chance, but some studies suggest that very heavy smokers may have an up to a 1 in 5 chance. And the important thing to note on the graph there is that the risk never goes away. So that little green line you can see down the bottom is if you stop smoking at age 30, you maintain an elevated risk for the rest of your life. But the importance also is that it does drop away. So any time is a good time to quit. Now, lung cancer is not the only death caused by tobacco, and as you can see, there's multiple others, and it's a significant burden of disease in Australia. So the single greatest health benefit is never starting to smoke or quitting smoking, more so than any of our interventions and treatments. So that's not the only risk factor. There are other risk factors. Of course, they all pale in comparison to smoking. Now, when we treat lung cancer, we treat it according to stage and the patient's performance status and comorbidities. The importance of this graph is to show you that dependent on the stage, you have a very different outcome. If the tumour is caught early enough, and if we look at the blue line at the top, that's stage 1A, those are tumours of very small size, so 2 centimetres. They have a vastly better prognosis than a tumour at stage 4, which is where you've got metastases. Now, unfortunately, the vast majority of patients present with advanced disease, and so the overall 5-year survival in Australia is only approximately 14%. So with the acknowledgement that if we catch it early enough, we have a reasonable chance of curing the disease, there's been great interest in screening programs. This is not a new thing, and it's been going on for a very long time. It started off with sputum and chest x-rays, and there are multiple studies from the 80s and 90s that unfortunately ruled out sputum and chest x-ray as being a positive impact on decreasing cancer mortality. Then we've moved on to CT screening, and I'll talk a little bit more about that. And then there's the consideration of biomarkers, and a lot of research is being done at the moment to try and find biomarkers, whether it's molecular or genetic markers that will help predict or at least find us a good population to more closely target. So the largest screening trial to date, and the one that everyone quotes and compares to, is the National Lung Screening Trial from the US that enrolled over 50,000 people. Half of them underwent the screening program and half of them underwent usual care. They were all current or former very heavy smokers, though 30-pack years. And they were in the at-risk age groups. The vast majority of lung cancers are diagnosed over the age of 60. And the net result was that CT screening was found to reduce lung cancer deaths by 20%. So in that population, we saw that 1.33% of those screened died of lung cancer, compared with 1.67% in those not screened, which is it's the greatest positive impact we've seen from any lung screening test, but there were a lot of false positives. So if we look at that study, for every 1,000 people at risk, so being screened, 609 had negative screening tests, with 391 had a positive screening test. So that's a very high rate of a positive screening test. So a positive screening test was essentially finding a nodule on the CT scan. Now, with ongoing follow-up, and there was a protocolized means for proceeding to further scans or investigations, it turned out that 377 of those were false positives, did not have a lung cancer. 14 had lung cancers. So what does that show us? That essentially shows us that out of 320 people screened, there was, over 3 years, there was 1 lung cancer death reduction. 95% of the tests were false positives. But most of those did not have invasive testing. So most of these false positives were ruled out through subsequent CT scanning. A back of the napkin estimate, however, suggests that to save 1 life, you're probably looking at a cost of about $500,000. Now, this is a low-dose CT scan on the right and a conventional CT scan on the left. And as you can see, the nodule is visible in both. Low-dose CT scans were used because they delivered a lower effective radiation dose, because we were always concerned about the impact of our interventions, and particularly our CT scans. And you can see the standard dose from a CT scan, low-dose CT scan, and what we're seeing now are actually ultra-low-dose CT scans. And if we compare this to a X-ray, there's not much more dose delivered. Now, of course, we all have a background radiation dose we receive every year, and all of our doses are compared to that. So you can see that by having a low-dose CT scan on these studies, you are getting the equivalent of 6 months extra background radiation. And that effective increased radiation that was estimated to come from the National Screening Lung Trial theoretically gives a risk of a 1 in 2,500 chance of dying of a lung cancer death. So it's not so easy. There is a health department document on screening and why we haven't proceeded with screening. And these are essentially the reasons. These questions need to be really answered before any screening program can be recommended. So do the benefits outweigh the harms? In this case, we possibly think they do. And indeed, if you look at the reduction in lung mortality, it would seem to suggest they do. There are concerns, however, about the anxiety of screening programs and the interventions required and the high number of false positives. So to target a better audience, we need to define the appropriate screening population, work on our diagnostic protocols, work on the screening protocols, work on the cost effectiveness, and effectively find the right target group. So essentially, screening is not ready for prime time. So if screening is not ready for prime time, and we can't use screening for early detection, we're really looking at case detection, which is based on suspicion. Now, of course, you'll all be aware of the likely symptoms that somebody might present with lung cancer. These are not new, they've been around forever. There are also signs, and in particular, this is a picture of clubbing, but any lymphadenopathy in the cervical supraclavicular regions, superior vena cava obstruction. These are all things that are signs to be mindful of. There is another very good site that shows the signs and symptoms and the means as a guide for GPs on how to assess these and how to proceed with investigations. And this is where that website would lead you to. And this is a very good single-page printout suggestive of how to handle a patient who presents with these suspicious symptoms. Now, I've just expanded on the top there, and the key thing is around this 3-week period. Now, there is some evidence through the UK that a cough duration is indicative or maybe predictive of a lung cancer diagnosis. So the take-home message, I think, from this is have a look at that website, have a look at this piece of paper, and just think about it. Essentially, anyone with a new or persistent cough over 3 weeks should really proceed to have a chest x-ray. Now, as you'll recall, I just talked about chest x-rays not being useful to reduce lung cancer mortality. Now, that's in the screening scenario. What you're doing is case detecting, because these are patients who have symptoms. So this schedule basically works a way through a chest x-ray, what to do with those results and when to refer. The only thing that I would disagree with in this document is you have a high clinical suspicion. This alone is not going to be sufficient. So you'd really just organise a CT and probably organise the referral. So if you wish, we could print out some of these and have them at the morning tea, maybe.
Can you just go back to their website address, please?
Yep.
Yeah.
What we could do is we'll be sending out an email, as I said, following, so we could have that as an attachment rather than having running around trying to find a way.
Because that's a summary of everything you need to know, really. So what do we do when you refer us a patient who has a lung nodule seen on a chest x-ray or a CT? We generally have well-developed protocols of following these patients. And not every nodule is a lung cancer, and indeed, when you've got a 4mm nodule, your chance of a lung cancer is less than 1%. But by the time that nodule is 8mm, you're up to a 10 to 20% chance of a lung cancer. And internationally, we all tend to follow these guidelines or very similar guidelines. If you have a concern or you have a patient who you have a nodule in or you have a concern about a lung cancer, if you go to our PETAMAC website, you'll see there's some quick links there about referrals. In specific, specifically, there's links about referral to the lung service, and so there's fax, phone and email contacts there. We have lung cancer nurse coordinators, and we're lucky we have 2 of them. And this is a study from the UK that shows that if you refer a patient to a hospital that has a lung cancer nurse coordinator, they are vastly more likely to receive active treatment. When you refer the patient to us, they come into our clinic. We perform a usual history and examination, diagnosis and staging. I won't go into those. All patients who we have any plan to treat radically, or even a lot of patients who we know are palliative but we wish to obtain greater information for targeting, will undergo a PET scan. You can see the CT scan on the left, the PET scan on the right. Shows you that not everything you see on the CT is actually functionally involved with lung cancer. We know that PET scans improve the outcomes of patients with lung cancer. CT and MRIs of the brain. Almost all patients we treat radically will have brain imaging as well to complete staging. When we decide and how we decide to treat a patient all depends on their staging. So we use the TNM, so the tumour, node and metastases staging. We roll that together into staging groups, and this is a very simple chart, and it also shows you largely how we treat these patients. So patients who are found very early generally will have surgery. Patients who are found to have a single pulmonary mass with no nodal involvement will tend to have surgery. Those who have nodal involvement at the hilar regions alone will tend to have surgery. Those who have nodal involvement involving the mediastinal nodes will tend to have chemoradiotherapy. And those who have disease beyond will tend to be treated palliatively with a combination of chemotherapy, radiotherapy or others. But of course that's all very case dependent, and a lot of our cases are elderly people with multiple comorbidities which influence how we treat. So this is the typical 5-year survival, and as I show, it just shows the range you have dependent on the stage. So finding a cancer early is what it's all about. So as I say, stage 1, typically surgery. If it's inoperable, we will consider radiotherapy alone, or chemoradiotherapy, or stereotactic radiotherapy, and we'll talk about a few of those later. Patients are worked up for their fitness for surgery, which generally involves respiratory function tests, but may also be CPX testing, looking at cardiac function as well.
Sorry, Mark, would you still operate on them if they're still smoking?
Yes.
Yeah, okay.
Yes. Yes. These are people who I find it very hard to give up. Often it's the greatest, impetus for them to give up, and gives them a lot of motivation to give up. But you can't wait for them to stop smoking. We do know that smoking does give us higher post-operative risk factors and chemoradiotherapy side effects and toxicities, but there's no option. So stage 3, so this is involving the mediastinal nodes, will be predominantly treated with chemoradiotherapy. Stage 4, best supportive care, maybe radiotherapy, chemotherapy, targeted agents. There is in very small print there, radical management for oligometastases. So one of the buzzwords that we all use now is oligometastases. So there is a line of thought that potentially, well, oligo meaning few, metastases, metastatic disease. There is a line of thought that there will be some cases who may have one or a couple of metastatic deposits that may be the limit of their disease. Now, there's also the line of thought that most cancers are metastatic at diagnosis. But if we do treat patients who have very limited metastases aggressively, we aim to try and create a more durable control of their disease, and there is mounting evidence to suggest that this may be the correct technique. Now that's something that's generally previously only been done in trials at very specialist centres, and we'll talk a little bit more about that towards the end. So at all stages as well, we're a large hospital, we have a lot of supports and we have access to all of these groups, and we use them. We probably don't need to go into patient selection for radiotherapy. By and large, the vast majority of patients we see are palliative in nature, and palliative radiotherapy makes up the bulk of our work. It's used in multiple scenarios, mostly for symptom control. Is it effective? Based on prior studies, we know that palliative radiotherapy can be very effective for some of the symptoms of lung cancer, particularly hemoptysis, chest pain, cough. There are very few emergencies in radiotherapy, and this is a perfect example of this is the fact that Peter Mac is the only centre that has a machine open on the weekends, and that machine is generally open Saturday morning unless it needs to be open at other times. Now, the emergencies that we get really are spinal cord compression. Everything else can generally wait for a few days without a negative detriment. But spinal cord compression is our only true emergency. And these patients typically present motor or sensory changes or a loss of bowel or bladder function. So we take note when we ever hear our patients say that they may be off their legs or having difficulty with their bowel and bladder function. It is truly an emergency, and we know that early intervention increases one's ability to maintain neurological function, particularly mobility. And we manage this with correct investigations, MRIs, steroids, neurosurgical opinions, and radiotherapy. And like all good emergencies, there is a prevalence of them on Friday afternoon. So let's move on to some radiation side effects and what you would typically see from a lung cancer patient. When we undertake radiotherapy, we think of patients as having a radical radiotherapy course or a palliative radiotherapy course. The difference in those is duration and dose. So with palliative radiotherapy, our goals are to relieve symptoms and do the least harm. So we very seldom see any side effects of great significance in that group. In the radical group, we're trying to do everything we can to control and eliminate their disease. And the typical course of radical radiotherapy goes for 6 weeks, Monday to Friday for 6 weeks, 30 treatments. And it's given with chemotherapy. And so those two modalities often overlap and magnify their toxicities. So we see patients weekly, at least during their treatments, in an effort to manage their toxicities and propel them forward. At the end of our treatment, so whenever you have a patient who's been treated with radiotherapy with lung cancer, we will generally do a simple discharge letter with the key side effects that we expect that patient will experience or may be experiencing and how to treat those. And we will generally be following up these patients within a week or two of them finishing their radiotherapy, dependent on how we feel they'll do. We think about radiation side effects of those that occur in the acute phase, so during the course of radiotherapy or within a few days afterwards or weeks afterwards, the subacute, which is many weeks or months down the track, and then late, which may be many years down the track. So most patients who go through radiotherapy will describe fatigue and tiredness. Now, it's always a mystery to me as to how a lot of our radiotherapy creates this particularly in some cases where we're treating very, very small sites to very low doses. But of course, it's often very multifactorial. But if you ask about it, you will find it. We have one acute side effect of people having radiotherapy for lung cancer that causes us great distress, and the patient great distress, and that's radiation esophagitis. So effectively, in order to get radiation esophagitis, you need to have radiotherapy passing through your esophagus, and it needs to be of a fairly high dose. Now, when we are treating patients radically with chemoradiotherapy, we see this in approximately 20 to 30% of patients. And effectively, it's the same process that's happening on the skin, but it's happening inside the esophagus. So it's uncomfortable for patients to eat and drink. They start losing weight. And down the track, it can lead to a radiotherapy stricture, which may require intervention with gastroscopies and dilatations. How do we manage this? So it's simple pain relief. It's empiric treatment where the goals of it are to try and keep the patient eating and drinking, keep their nutritional intake going, and get them through the remainder of their course. Now, in most cases, this can be handled with pharmacological means, but sometimes we need to insert nasogastric tubes towards the end of our treatment, and if they are inserted, they may be in for anywhere from a couple of days to a couple of weeks. Most patients will not need to be admitted because of radiation esophagitis, so it's something that is generally managed in the community or as an outpatient basis. Our other concern is lung injury, which tends to be a subacute or a late effect. Now, and a lot of this is predictable when we go through our radiotherapy planning. We can reasonably predict who's likely to obtain sufficient lung dose that they are at risk of lung injury. And radiation pneumonitis is our greatest acute concern, and people do die of this. It doesn't occur during the course of radiotherapy, it always occurs afterwards, and it's managed principally with steroids. Those who are particularly unwell may need admission, oxygen support, respiratory physician input. This is an example of radiation pneumonitis, and if we look at the CT scan on the on your far right, this is a CT taken 6 weeks after the end of a radiation course. You can see air bronchograms in that. You can see the infiltrate. And then if you look at the subsequent scans, I think the next one was about 3 months later and then a year later, you can see that that radiation pneumonitis has decreased, and what we're actually left with is fibrosis and scarring. This is another example of a patient who had a radiation pneumonitis. On your left is their diagnostic PET scan, and that is their cancer. You can see that's FDG avid with the crosshairs on it. 3 months after the end of radiation, they had another PET scan, and as you can see, a very big infiltrate there. That is radiation pneumonitis, and you can already see that the actual cancer itself seems to have melted away. And then if you look at the far right there, 2 years later, the chap now has a little bit of uptake in that site, which is very difficult for us to determine whether that could be some tumour recurrence or some residual activity at the area of inflammation. This is the same chap, but I've now put in the radiotherapy planning data on your far right. Now those rainbow colours all represent dose, and you can see from the middle PET scan here where the you have this big area of FDG avidity. This corresponds perfectly to where the large dose went in. So one of the things that we use when determining whether we've got a radiation pneumonitis or another pneumonic process is its relation to the radiotherapy fields, and you will often see razor straight edges of areas of radiation pneumonitis which correspond perfectly with where the radiotherapy field passed. Skin effects, acutely in the top there, and at the bottom late effects. So Most acute effects resolve, and you may require some dressings for a short period of time. In lung cancer, typically these would appear on the back. The patients are usually in a place where the patient cannot see, and they will resolve within a couple of weeks of the end of radiotherapy. For very high doses delivered to the skin, when we intentionally want to treat the skin, you're much more likely to get late effects such as the telangiectasia you can see in that bottom screen, and you can see the razor sharp edge which would correspond perfectly with the radiotherapy field. Of course, late side effects do occur, and if you have a look at that CT scan down the bottom there, you can see an area where you've got stenosis of the coronary vessels, which occurs in a straight line down here, which corresponds with where he would have had a radiotherapy beam edge coming through there. So why are late effects an issue? There are approximately 1 in 800 people are cancer survivors in the community, and these are often people who have received radiotherapy or chemotherapy as a child, and with children we're expecting 60 to 80% to survive, and they have a long time to experience side effects and toxicities from their radiotherapy treatment. The longer you live for after your radiotherapy treatment, the greater the incidence or the risk of side effects. And the little quote down the bottom there is what is a very, it's a real life quote from one of our colleagues. Now, we do have a late effects clinic at Peter Mac, and it also operates out of several of our satellites. Now, in the past, it had previously been for children, but we are taking late effects from any long-term survivors. So any cancer patients who you may have who have had long-term toxicities, we would be interested to see in our late effects clinic. And information about that late effects clinic, and indeed this document also is a 93-page document that tells you what to look out for different chemotherapy agents and radiotherapy to different sites for different diseases. It's a big document, but it's available. So just a few of the newer sort of agents that we have, and some of our new toys that you will hear patients talking about or see in the media. Stereotactic radiotherapy, this is not a new thing. It's been utilised in the brain for 30 or 40 odd years. We are now starting to use it outside of the brain. In particular, we've had a great uptake within the chest. And why inside the chest? Because we have these two large big caves with not a lot of important stuff in there, surrounded by a lot of lung. Essentially, stereotactic radiotherapy is different from conventional radiotherapy in that we can deliver ablative or curative doses in a single treatment or even a couple of treatments. We can only treat very small lesions because we're treating with very, very high doses through multiple beams, and effectively our dose gradient drops away. So if we're treating this very small lung cancer here, you'll see this green line here is our target dose, and by the time we're out to this purple line, we're at 1/3 of the dose, and by the time we're out here, we're out to so about 1/6 of the dose. So it allows us to treat very high doses to very small regions. And if you click on that AVI, we'll see how we go there. So this is a typical sort of stereotactic plan. All of these are beams passing in from different angles, all intersecting at the one point where we want to deliver the dose. Try clicking on that. So this is essentially what we do when we're planning. So this chap has had their carina, their proximal bronchial tree contoured, the spinal cord. So during treatment, at the start of treatment, midway through treatment, at the end of the treatment, we're actually doing a little mini cone beam CT, so a little mini poor man's CT on our treatment machine, and we're aligning these, so we're within millimetres of accuracy. We know that it works, and indeed these are sort of papers looking at 3-year local control of pulmonary nodules, and as you can see, on average they're between 80 to 90% control, which rivals that of surgery. And this is one study looking at a comparison of wedge resection, which is how the surgeons generally manage metastases to the lung or a pulmonary nodule as compared to stereotactic radiotherapy. So we're within the same ballpark there. There has recently been a published paper which was an analysis of 2 papers that were comparing a lobectomy, which is the standard surgical approach for an early lung cancer, to stereotactic radiotherapy. Unfortunately, both of the studies that it looked at failed to accrue. So this is effectively underpowered, but is very suggestive of requiring further research, because there may be a fading importance of surgery in these groups, particularly when we consider that a lot of our patients are elderly and unwell. And indeed, where stereotactic radiotherapy was taken up in the Netherlands, they were treating a lot of elderly people who had been declined by the surgeon for surgery, and they had noticed an increase in their survival. Now, this is a very old paper from the lung metastectomy study, which was over 5,000 lung metastases. So these are patients who have had a primary elsewhere in the body and had a single deposit in the lung due to different tumours. And as you can see, this is the result of the surgeons removing those metastases to the lung. Now, the take-home message simply is that about 20% of these people are long-term survivors from resecting their metastatic disease. And at the moment, there are other studies underway looking at the role of stereotactic radiotherapy as opposed to surgery in treating these patients. Now, just within lung cancer, it's been the perfect model to explain targeted agents. I know you've probably just had a discussion around some of these. When we think of lung cancer, we decide how to treat it based on histology. So there are 4 main histologies. There's these 3 and small cell. These are all considered non-small cell lung cancer. Now, these don't make a difference for radiotherapy because we treat them all the same, but they make a big difference for our medical oncology colleagues. Within the adenocarcinoma group, we're aware of mutations, and in fact, 64% of patients can be found to have a mutation that is potentially targetable. Now, at the moment, there are 3 mutations that are readily targetable, or really there are 2 that we have targetable agents for. So that's EGFR and the EML4 ALK. So now when a lung cancer patient is diagnosed with an adenocarcinoma, beyond histopathology, we will also be doing molecular testing. So these are the 3 that we really test for: EGFR, KRAS and ALK, and they all tend to have a general phenotype. The EGFR and ALK, for which we have targeted agents, are generally in never smokers, younger people and often females. And these drugs can have a very dramatic effect. This is a PET scan on the left of a patient at diagnosis, and this is following their targeted agent on the right. And we are seeing very long survivals in some of these patients, and patients that we would expect to have passed long before, we're often seeing them years later. We see that these drugs work better than chemotherapy, so if you have these mutations, you have another avenue of treatment. This is another example of a CT scan before one of these drugs and then after, so they can have very, very dramatic effects. And we don't see these sorts of dramatic effects with chemotherapy. Another avenue is immunotherapy. And there's a tumour cell being surrounded by T cells. And in lung cancer in particular, there is a new drug that we've found. we didn't find it, generic we found it, that is again better than chemotherapy. So there's a booming area at the moment within targeted therapies and within targeted treatments. So stereotactic radiotherapy and these targeted drugs are what you will hear a lot about in the media and from your patients in time to come. The end.
Thank you. Has anyone got any questions for Mark?
Any radiotherapy side effects to the myocardium or pericardium?
Yes, so the answer is yes. So within lung cancer, because of the dismal prognosis as a whole, it's not something that we have that we've ever altered our treatments for. And indeed, paradoxically, we've often chosen to dump our dose in the heart to avoid depositing it in the lung. Now, you can sort of say that's paying off Peter to pay Paul, because we're trying to avoid those short and subacute side effects of radiation pneumonitis, fully aware that we are exposing our patients down the track to potentially greater cardiac problems. But in order to have those cardiac problems, you need to be a long-term survivor.
But as GPs, if we've got one of those long-term survivors, should we be looking out for this kind of thing and monitoring?
Yeah, so I think it's just an awareness. It's an awareness.
Yes.
The
Okay.
next message on from the transfers that you told, we encourage the GP to use that one in the home setting or in the nursing home where patients are being looked after by the GP before transferring to the hospital.
So if you're talking about a spinal cord compression or a suspected spinal cord compression, yes.
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 So for how many days will you encourage?
Well, hopefully you would just be giving them one dose, because they would be on their way to the hospital.
Just one dose and send them home, send them to the hospital.
No, yeah, not home. Yeah, so really, it truly is an emergency, and we know that earlier we can intervene dramatically increases our chance of maintaining that patient's mobility, and maintained mobility leads on to sort of prolonged survival and quality life. So if you suspect that a patient has new neurological symptoms and you are concerned, you know they have a history of a cancer, then we would want a referral to an emergency department straight away, or if they are known to us, we would be happy for us to be contacted. Now, at the moment at Peter Mac, we don't have an emergency department, but we do have clinics every day, and we do have an acute assessment ward, so we do have the capacity to assess these people. And indeed, when we move to Parkville, we will have the emergency department. But essentially, it is the only true emergency that we become concerned about with radiotherapy.
This gentleman here.
And then the carcinoma of lung is not related to smoking, right? So what the risk factor about the adenocarcinoma of lung? Is adenocarcinoma of lung prognosis is better than squamous cell lung cancer?
No. So they are all related to smoking. There may be a preponderance within other subgroups of that, but if you're talking about those molecular mutations, so we see. So within men, 90% of their lung cancer is due to smoking. Within women, it's about 65%. Now, we do have those other mutations that we tend to see in patients who have never been smokers. So we know there's other factors, but the smoking is just the single biggest factor we have.
What about the prognosis? Adenocarcinoma of lung is better than the squamous cell lung cancer?
That's very interesting. Because
I saw a patient, she's a very old lady.
Yeah.
In Queensland, she has adenocarcinoma.
Well, it's difficult because squamous cell is often doesn't spread as quick. So we often see squamous cells that have reached a large size and remain within the chest cavity. So that means that we're often more inclined to treat those patients radically. Whereas on the flip side, adenocarcinomas can often be very small, but it can have metastasized earlier. So it's not so much the histology, but it's the staging that's important in that regard. But there are always outliers, and we all have patients who have presented with a single metastases, and in particular brain metastases, that's been resected, their chest has been radically treated, and they are long-term survivors. So it's really the stage as opposed to the histology in that regard.
Our normal scenarios, we get a CT scan that says it's suspicious of lung cancer. Do we send them to respiratory physicians for bronchoscopy, or do we send them to...
Yeah, so in general, it's a respiratory physician. Now, of course, any large hospital such as Peter Mac has respiratory physicians, and throughout their clinics, they are lung cancer respiratory physicians, and they are triaging, diagnosing, following up, and so forth. So when you get a CT report that returns with a finding of a lung nodule, then we're happy to see that patient straight away as a referral. So you can refer to a local respiratory physician, or you can refer into a hospital. The key thing is you would want to refer to somebody who is affiliated with a multidisciplinary clinic, because that is sort of where we really are able to treat these patients with evidence. Now, ironically, we've actually been looking at the time to treatment, because we're all aware that there's a lot of patients who end up starting their treatment very late through one reason or another. And we're going through our records at the moment, looking to see where those long lengths of time can be cut down. Where are the holes that these patients fall into? And ironically, some of the stuff we've seen is from peripheral GPs who don't have local respiratory physicians, so they don't have the option to refer a patient to Mr. X who comes every fortnight, and they refer them straight into our clinic. And these patients are often the ones that get to have treatment first. So I can't suggest that everyone refer everybody straight to Peter Mac, but I think in the future, I think we're going to see very well coordinated networks. And indeed in the UK, they have a system at the moment where whenever a radiology department finds a lung nodule, they refer the patient to the clinic, to the central clinic, with a note to the GP on the way.
Just one more question.
Yeah, just wonder what I went to do after initial X-ray, just saying no specific bronchitis, but the symptom persists.
Yeah, so that would be, so if they persisted, and I think the that sort of schedule has a program for that, you would eventually lead to a CT, or if you had a high clinical suspicion, then you would refer them straight for a CT. But otherwise, I think they recommend a 6-week wait and persisting symptoms. But if you have anyone who you're concerned about, and you have that sort of just vague sense of unease, we would be much happier to see that patient earlier rather than later. I know this is the hard thing, and that's why they try and produce documents to try and make that pathway easier. But we would much rather see more patients than less patients.